59-year-old lady, Mrs. MM. On June 4th, she had taken a COVID vaccination. On June 4th, she has taken her COVID vaccination, second dose of Covishield, followed which she developed on June 5th headache, which was acute, severe, and generalized, associated with nausea, followed by one episode of vomiting, which was non-projectile and non-bilious, associated with the fever, one episode, low grade, continuous, not associated with chills or rigor, relieved on taking medications.
Okay. Now, at this point of time, the patient has come to you on day 2, June 5th, on day 2 after taking the vaccination. What is your thought process? How will you manage this patient at that stage? What do you think is the problem?
So initially, because of vaccination, usually followed by vaccination, there will be problem with symptoms of fever, headache, but not vomiting, not so frequently. So that's like post-COVID vaccination myalgia, fever, sequelae.
Okay, good. So at this point of time, when the patient comes to you in casualty or OPD, you think it is a non-specific reaction to the vaccination. So what will you do now? Investigation, management.
Investigation, just a routine investigation, CBC, and management like antipyretics, symptomatic management.
What will you give? You are a doctor now.
It's a paracetamol.
Okay, so there's no need to do any investigation. You just put the patient on paracetamol, 650 mg 3 times a day. And what is the instruction you will give?
Review if any new symptoms or if it is worsening or if it is worsening.
Very good. So please give a caution to them that if the symptoms continue to worsen or if you develop any new symptom, come back. Good. Okay. Then what happened? Next.
On June 7, she developed a slurring of speech, which was noted by the relatives. That they didn't consider that as much of a problem. On June 8, there was increase in the slurring of speech associated with the confusion, word finding difficulty, and restlessness.
Okay.
But there was no history of loss of consciousness or seizure episode, or any neck pain, or any trauma or ear discharge. No history of palpitation, syncope, chest pain, or breathlessness. No history of hemopine pain or animal bite.
Why did you use the word animal bite here? You know that something is happening after the vaccination. Okay. Now, so on day 2, you felt that very rightly it is a non-specific post-vaccinal symptoms. And you told the patient to come back if there is any new symptom. Now the new symptom is a slurring of the speech. What does slurring of speech mean? How do you interpret this symptom? It's due to what? What is the anatomical structure for slurring of the speech?
Higher mental function, like brain parenchyma might have affected.
Pardon?
Or higher mental function, or
what do you mean by higher mental function?
Brain parenchyma might have been affected, or any local disarticulation, like kind of picture.
No, if you just only take slurring of the speech, suppose the patient comes to you only for slurring of the speech in the OPD, what we know is it a dysphasia or dysarthria? Can you differentiate dysphasia and dysarthria?
Yes, sir. Dysphasia is due to cortical involvement. Dysarthria is due to articulation defects in the.
So the slurring of the speech is basically articulation problem.
Yeah.
It can be corticospinal tract, lower motor neuron, extrapyramidal, and any other long tracts can give rise to slurring of the speech. But the important thing is, next day she developed confusion, unable to find the words, and restlessness. Now, what does this mean? What is happening now?
So it is not a disarticulation kind of picture.
Pardon?
There is an involvement of brain. It is not due to disarticulation, sir. There is involvement of brain parenchyma.
Okay, so what we said non-specific symptom, now it has become a specific to involvement of cerebral involvement. So specifically now the focus is shifted to the brain, cortical or subcortical area, giving rise to acute confusional state. In the acute confusional state, the patient may be having difficulty to talk, maybe due to slurring of the speech, may be part of the acute confusional state rather than an isolated speech involvement. So now what we are seeing is a totally different picture. We call this as, at this stage, it is an acute confusional state. Okay, so now we'll have to investigate for cerebral involvement. Okay, next slide.
So past history. She is a non-diabetic for 4 months, metformin, and hypertensive since 1 year on telmisartan 40. No other significant past history.
Okay. Next.
General examination. On examination, she was drowsy but arousable, confused, and in supine position. She was not oriented to time, place, or person. No pallor, icterus, cyanosis, panopathy, or edema. Pupils were bilaterally reactive, moving all 4 limbs. There was no neck stiffness. Vitals BP 140/80, heart rate 86, respiratory 18, temperature febrile. JVP is not elevated. Other systemic examination is non-contributory. Cranial nerves not able to assess.
So at the end of this examination, what is your impression? You are dealing with what?
Acute confusional state.
Acute confusional state. Very often, when the patient comes to the casualty with acute confusional state, the doctor also is also in an acute confusional state. What is happening? You understand? So you see the evolution. Patient came with headache, mild fever, body pain. So non-specific symptom we thought on day 1, but very rightly patient has been instructed to come back. There are new symptoms, and she came with a confusional state, which is responsible for slurring of speech, which is responsible for not able to identify people or word finding, etc. And your clinical examination has shown and confirmed that we are now dealing with a case of acute confusional state. Okay, next.
To motor system examination, patient is in supine position, both upper limb and lower limb is extended. There is no muscle wasting. Bulb is on. Bilateral upper limb and lower limb, proximal and distal is normal. Power bilateral upper and lower limb 4/5.
Okay. How did you
is not
go back? How did you determine the power is 4/5? You see, the moment you say 4/5, that means you are thinking of a neurological motor deficit. You understand? In a patient who has got acute confusional state, when the patient is not able to follow your commands, to say that 4/5, that means the patient 5/5 means the motor power is normal against your resistance. The resistance offered by you, she is able to work against your resistance. Now, if the patient cannot understand, how can you make a comment it is 4/5? In a confusional state, all we are interested to know is whether the patient has any lateralizing deficit. That means, does the patient have a hemiparesis? It is extremely important to know in an acute confusional state whether the patient has a lateralizing deficit like hemiparesis, because that will tell us there is a structural damage to the brain. We'll come to this later on, the difference between encephalopathy and encephalitis and the focal encephalitis. So what is most important in clinical examination of an acute confusional state is to know whether the patient has any localizing or lateralizing deficit. What do you mean by localizing deficit? 6th nerve palsy, 7th nerve palsy, which will tell us there is a localization, which means there is a structural involvement or a hemiparesis. So if the patient is restless, observe whether the patient is moving both the hands equally or all the time moving only one hand. So you may pinch the other hand which is not moving and see whether that hand also starts moving, or when you pinch the left hand, only the right hand moves. That means the patient has a paucity of movements on the left side. That means there is a focal neurological deficit. I think this is the most important clinical examination in a patient who comes to you for confusional state, or in a patient who is drowsy also. Even in a patient who is drowsy, you have to find out by pinching whether the patient moves both the upper and lower limbs equally or not, because that will give you a pathway for a diagnosis. This is an extremely important point. So don't make a comment that 4 by 5. All you can say is power cannot be assessed, but moves all the 4 limbs equally well, spontaneously or to painful stimuli. That should be your notes. You understand?
Okay, sir.
Okay.
But sir, if she is moving against gravity, can we comment like that?
Pardon?
Moving against gravity, can we comment like this?
No. In the motor power, all you have to say is moves both upper and lower limbs equally well, spontaneously moving or moving with painful stimuli. That you will have to make a comment.
Okay.
Okay, next.
Not possible to elicit. There are no abnormal movements. Reflexes, superficial reflexes, bilateral, plantar reflexes or flexor. Reflexes are normal. And sensory system only responsive to pain prick, it is normal. Gait is not a curiosity to elicit.
So for a pin prick, the patient moves the limb where the pin is there, or patient moves the other limb.
Yeah.
As I told you, if you pinch the right upper limb, patient moves only the left upper limb. That means there is a paucity of movement on the right side, or there is a loss of sensation. But if the patient moves the limb which you are giving a painful stimulus, that means there is a both sensory and motor are intact in that particular limb. These are the important clinical examination in a patient who is brought for confusional state, or even in a patient who is drowsy, or even in a patient who is unconscious. These are very important to know whether there is any lateralizing, that means hemiparesis, or localizing. You do an ocular movements in a patient who is unconscious. If you find there is a sixth nerve palsy, unequal pupils, that means there is a structural damage. Okay, next.
Diagnosis: neurodeficit is acute confusional state. Anatomical diagnosis is involvement of the bilateral cortex. Pathological diagnosis may be encephalopathy or encephalitis. Etiology: query post-COVID vaccination.
Right. So it is a global cerebral involvement. We use the word global cerebral involvement. That means there is no focal deficit, but there is a global involvement of both the cerebral hemispheres. It is not one cerebral hemisphere. It is a both cerebral hemispheres are affected. Largely, it is a cortical and subcortical involvement, because the deep white matter or basal ganglia do not cause this acute confusional state. The cortex or a subcortical area is the anatomical localization. Global cerebral involvement, further defining the anatomical, cortical and subcortical involvement. Now, with the clinical features of only a generalized global involvement, we do not know whether it is encephalopathy or encephalitis. What is the difference? Encephalopathy and encephalopathy, you very rightly said etiological diagnosis. Because it followed vaccination, we'll have to check the literature and see whether there are any reports where the post-COVID, immediately a post-COVID vaccination. Post-COVID, there are plenty of neurological complications, right from encephalopathy to myopathy. Encephalopathy, myelopathy, facial palsy, GB syndrome, myopathy, everything is affected. But after vaccination is a very difficult thing, because if there are many complications after vaccination, people will stop taking the vaccine. You understand? So you must be very, very careful to make a diagnosis of post-COVID vaccination complication. You have to search the literature and see whether there are any reports. And yeah, now what is the difference between encephalopathy and encephalitis? What is the next slide? What is the next slide? Let me see. Yeah.
Sir, encephalopathy, clinically both present as the same, sir. Confusion, disorientation, and altered sensorium. But encephalitis, fever may be present. Encephalopathy, fever may or may not be present. In both, generalized seizures are present, and in encephalitis, a partial or focal seizure may be present. But in encephalopathy, it is global involvement, so focal seizures will not be present.
What is that? What is that?
Metabolic.
Encephalitis can be focal or generalized, but encephalopathy is always generalized. Global involvement.
And metabolic derangement is present in encephalopathy. It's not present in encephalitis. Then neck stiffness is not present in encephalopathy. It may or may not be present in encephalitis. Along with the neurodeficit, which also may be presented in encephalitis. And EEG abnormality shows generalized abnormalities in encephalopathy, while it will be focal or generalized in encephalitis. And MRI brain will be normal, and in encephalitis it will be normal or abnormal. CSF will be normal in encephalopathy, while in encephalitis it will be abnormal. And causes include metabolic, toxic, or electrolyte disturbances in encephalopathy. In encephalitis, primarily due to infection, will be bacterial, viral, or tuberculosis.
This is very extremely important slide, which all of you must understand in your clinical practice. When you see a patient coming into the ward or in the casualty in an altered sensorium, drowsy or unconscious, encephalopathy is nothing but involvement of the brain, encephalon. Like neuropathy, myelopathy, myopathy. It only means that particular structure is involved. So the encephalopathy's brain structure is involved, whereas encephalitis is a inflammation. So most often the inflammation can be infective or non-infective also, but there is a definite itis, there is an inflammation. So when I say inflammation, how do you make a diagnosis? Laboratory diagnosis is CSF. Gold standard is CSF. CSF shows evidence of inflammation or infection causing inflammation in terms of cells, protein, and sugar. Encephalopathy, remember, we come across a lot of patients with encephalopathy. Common causes are diabetic complication, hypoglycemia or hyperglycemic non-ketotic acidosis. More common than that is hyponatremia. Hyponatremia is the commonest cause of encephalopathy we see. A patient who is on antihypertensive drug with a diuretic added to that, when he is brought to the casualty with acute confusional state, we do a sugar and we do a sodium. These two are extremely important because both are the common causes in clinical practice and both are totally reversible if you find out at the appropriate time. So have in your mind a clinical picture, encephalopathy or hyponatremic encephalopathy. Have in your mind encephalitis, a viral encephalitis. Then you will know what is the difference between encephalopathy and encephalitis. The most important laboratory test to differentiate the two is the CSF examination. Mind you, a patient can have 128 sodium and yet can have a encephalitis. You understand? So you must have a proper clinical diagnosis that it is a encephalopathy. The commonest cause of encephalopathy is electrolyte disturbance, sodium, and metabolic, commonly hypoglycemia, but it can be what other metabolic conditions? Hello?
Sir?
Are you attentive or not? What other metabolic conditions causing encephalopathy you see in day-to-day practice?
Thyroid.
General medicine.
Thyroid, myxedema.
Very rare. Tell us common things, please.
Hepatic encephalopathy.
Huh?
Hepatic encephalopathy.
Hepatic.
Hypertensive encephalopathy.
Renal,
Delirium.
renal and hepatic. Renal and hepatic after the sodium and glucose. After sodium and glucose, the common causes of encephalopathy in clinical practice under general medicine, you see oftentimes patient is admitted for hepatic or renal encephalopathy. So please remember, a lot of these metabolic causes are reversible. That's why it is extremely vital to make a differentiation between encephalopathy and encephalitis, and the usual run of investigations go through all the metabolic parameters. So it is important to go through all the metabolic toxic parameters. When you can't make out metabolic cause is not there, CSF is normal, then you go into the toxic causes, any drug-induced causes you will have to go into. For example, patients with carbamazepine, sodium valproate, some of these recreational drugs, any of these things can also come with acute conclusional state. So you have given a nice chart where you find that the difference between the two, encephalopathy and encephalitis. Let us proceed. Somebody has asked delirium. Sir, can we call Alzheimer's as encephalopathy? Certainly not, because that is a chronic disease. We talk of acute, both encephalitis and encephalopathy are acute or subacute. For example, paraneoplastic autoimmune encephalitis are subacute in terms of weeks. Encephalopathy is in terms of hours or a couple of days. Patient will not come after 15, 20 days or 6 months after a hepatic encephalopathy or a renal encephalopathy. You understand? So encephalopathies are always acute, few hours to a day or two. Encephalitis may be a few days. And Alzheimer's, brain tumor, all those things are several months and years in Alzheimer's. Delirium is only one aspect of acute encephalopathy or encephalitis. When we say patient is restless, then he may be so hyperactive and hypervocal. So he is in a delirious state, we call. So it is nothing but one aspect of acute cerebral involvement. Now the next question, post-traumatic brain injury, can we call it encephalitis or encephalopathy? What do you mean by post-traumatic brain injury? They don't come with encephalopathy or encephalitis. They come with altered sensorium, encephalopathy, and or unconsciousness, again encephalopathy. But there you have a clear-cut cause. Patient had a fall, a head injury, or somebody has hit his head. So again, it is encephalon involvement with a clear-cut cause that is called as a trauma. So you may call it as a traumatic cerebral encephalopathy. Yes, traumatic encephalopathy can be used the term. You are technically right, but we do not use that word traumatic encephalopathy. But if you find out the definition of that, yes, encephalopathy is involvement of brain and it is due to trauma. So that is also a correct terminology. Next slide.
Medical lab investigations, HP 13, total count 8,000, sodium was 128, potassium 3.56, creat 0.89, histotoxicity normal, ammonia normal, GRB is 198, ABG normal.
So what do you find here? Anything abnormal you have found?
Mild hypernatremia is present.
128 is not a very big number to say patient is in this state of affairs, but it may be contributory. See, sometimes it may not be responsible completely, but it may contribute to something else which is happening. But all the same, you will have to correct the hyponatremia. That don't get misled that you have found a cause and it is 128, so it is a purely hyponatremic encephalopathy. You need to investigate further. Next. What is the next investigation you do?
MR brain.
Yeah.
The patient presented on June 9, so MR brain was done on that day, which showed a bilateral occipital gray matter T2 hyperplanicities, suggesting signs of demyelination.
Can you show that?
Which can be seen.
The pointer there with your mouse. Yeah, correct. So you can see that it is a cortical and subcortical involvement, more on the right than the left. There is some changes there, altered signal in that area. So it was quite a bit of non-specific thing. You cannot call it as a demyelination. Please remember, demyelination occurs where there is a myelin. Where is the myelin? Myelin is in white matter. Cortex is a gray matter. So it is a involvement of a cortex and subcortical. What is the noise, please? Can somebody mute? Please mute yourself. Somebody. Hello. Can you mute yourself? One of you. So it is not purely demyelination. It is a non-specific involvement of cortex and subcortical area. Okay. Then what happened?
So she was started on antibiotics, steroids, and injection mannitol. Steroids injection methylpred 1 gram was given.
Okay.
On June 10th, marked improvement in the consciousness level. Patient was obeying all commands, knowing all 4 limbs.
Very good. So
confusion state has reduced.
What do you think on June 10?
Steroids.
What do you think is your diagnosis on June 10?
Same. Like.
Pardon?
Some inflammation.
Please remember, steroids will improve any clinical condition in a non-specific way. So don't conclude that this is a steroid responsive encephalopathy or steroid has caused the treatment. It is a totally non-specific improvement. You will see that after some time the patient deteriorates because the steroid is a whitewash, what I call as a Gangajal. In each and every disease, if you give steroid, the patient dramatically improves, but it is a very, very short-lived. Okay, so anyhow, patient has improved, but we'll keep a watch. Next slide.
So CSF was done on CSF was done on June 10. Color appearance was clear. 100 cells. Cell type more of lymphocyte. 90% was lymphocytes. Protein was raised 125. Glucose was low 40. GRBS at the time of LP was 208. So
okay, so the difference between encephalopathy and encephalitis is the gold standard CSF examination. Now, in this CSF examination, is it mere inflammation or is it infective inflammation? That is very important. How do you differentiate on the glucose? If it is an infective inflammation, the glucose level is low because the organism to live up consumes the glucose. In a non-infective inflammation, for example, a patient who has a old subarachnoid bleed, the blood is an irritant to the meninges and patient can have CSF abnormality, but you will never find low glucose. That's why it is imperative to have blood glucose drawn before doing a CSF because you want to correlate blood glucose and CSF glucose. CSF glucose is usually 1/3 of the blood glucose. So here you find glucose is very low, 40 may not be that low, but when you find 200 GRBS at that time, 1/3 of that will be about 65 or 70, but it is only 40. So definitely there is an infective inflammation. Please remember this point. Inflammation can be due to many other things, but we want to know infective inflammation because infective inflammation has a specific treatment, pyogenic, tubercular, etc. Or even herpes simplex virus has a specific treatment. Whereas inflammation CSF may not have any specific treatment. So it's very important CSF has to be done properly and the GRBS before that. Lymphocytes won't consume sugar, sir. It is the bacteria which consume sugar and some of the viruses which living organism. Why should lymphocyte consume sugar? Certainly not. cell count shows 90% lymphocyte is a not a pyogenic infection. So that is important. So when you find polymorphs are predominant, it is a pyogenic infection, very clear cut. Whereas a lymphocytic predominance can happen in non-specific inflammation as well as chronic infections like tuberculosis. So it is extremely important to get a CSF done in a proper laboratory because you are making a vital diagnosis on the basis of CSF. I'll tell you more about CSF when I talk in the second session. Next.
So on June 13,
so one second. So after the CSF, we know that it is not a post-vaccinal encephalopathy because sugar is less. It is an infection. It is not an inflammation of the due to the vaccination. It is an infection. So you cannot report this as a case of post-COVID vaccination encephalopathy. You understand the vital information which you got from CSF?
Yes, sir.
Okay, next.
June 13, steroids was stopped after a 5 days course, and the patient was shifted to ward, fully conscious, oriented, and obeying commands.
Right.
On the next day, she developed a seizure episode lasting for 1 minute, followed by rapid deterioration of conscious level, disoriented, and not obeying commands.
So, for the information of you and other attendees here, the Zoom will stop in another 4 or 5 minutes. I will come back after 10 minutes. Please again log in for the second session. Yeah, please continue.
She was shifted to ICU in view of decreased response along with altered sensorium. Injection midazolam stat was given and continued on antiepileptic medications. Mechanically ventilated in view of worsening sensorium, multiple seizure episodes, and the patient desaturated in ICU.
Okay, so as expected, the steroids only gave a whitewash or a Gangajal effect, and then patient had a seizure. Following the seizure, she became unconscious, probably aspirated, and required intubation and ventilation. And for the seizure, the anti-epileptic drugs are given. Okay, next.
And, on same day, MRI brain was done on June 14. It showed multiple focal T2 of flare hyperintensity with nodal enhancement in the right parietal occipital. This is the largest, and multiple other areas, suggesting nature or infective etiology. Granuloma with adjacent edema. And there is diffuse sulcal and subarachnoid space enhancement with supra and infra, and ependymal lining of the bilateral lateral ventricle, suggesting of extensive meningitis with ventriculitis.
So the second MRI showed two important things. One is a granuloma. Another is a evidence of meningitis. Shows the film. Can you show with your pointer?
Yes, sir. Same area.
So that is a granuloma. Okay. Yeah, I'll come back. Some questions are there. Antibiotics received, can it be partial pyogenic? And after seizure, what are MRI findings? We'll come back to those questions during my talk because there's just another 2 minutes are remaining for Jayashankar to present. Okay, I will show you these slides better in my talk, these same slides. Okay. So now the radiological report showed there is a granuloma and there is a meningitis. So that means we are dealing with commonest cause of granuloma with meningitis is tuberculosis in our country.
Yes.
Right. Next.
And repeat CSF was also done on June 14. Compared to the previous CSF, there was increase in the cell type was 100 lymphocytes, and their cell count was increased in the repeat CSF, along with increase in protein, but there was a decrease in glucose level.
Okay, so you find that the infection has worsened because the cell count has increased. You have not put the number elevated, and important thing is the glucose has come down further and protein also has increased. So whatever is the cause of infection, it has escalated, and there are now new MRI findings. So you remember to repeat CSF always. When you are not sure about the diagnosis, you have to repeat MRI as well as repeat CSF because These are dynamic changes. MRI and CSF are dynamic changes depending upon the clinical. You don't do a CSF if the patient is already improving. You don't do another MRI if the patient is improving. But as the patient has gone down, so you need to know what are there any new findings. Very rightly, repeat MRI and repeat CSF has given you a diagnosis now of a clinical diagnosis, granuloma with meningitis. Commonest cause in our country is TBM until proved otherwise. That means we start antitubercular therapy till we get some other diagnosis. Okay,
Yes.
next.
The patient was started on anti-tubercular therapy in view of the clinical and worsening MRI picture and the CSF picture. June 15, CSF herpes virus PCR came out to be positive. So, Stashon injection acyclovir, 10 milligram per kilogram TID, and the patient had a hyponatremia. Like sodium was 116, so started on 3% NaCl. There was clinical improvement in terms of conscious level, and there is no further seizure episodes from June 15 to June 20. On June 20, there was clinical worsening with altered acute in onset and rapidly deteriorating, but there was no further seizure activity.
So what is your interpretation here?
So June 15, started on anti-TB therapy. So after that, patient condition remained the same. Conscious level was improving.
So here the point I want to make is the CSF shows HSV PCR positive. Don't jump to the conclusion that this is a HSV encephalitis. Always remember, clinical diagnosis is extremely important. All laboratory investigations must add on. No laboratory investigation will give you final diagnosis, including histopathology. So if your clinical diagnosis is A and a lab says it is B, check your clinical diagnosis and then check your laboratory. See, nowadays CSF sample, they will do some 25 tests in one CSF sample. So it is very difficult to say that final diagnosis is because HSV positive. HSV has got a totally different picture. It is a focal encephalitis. I will tell you in my next 15 minutes my talk. So in this patient, if you see HSV PCR positive, you do not change your diagnosis. You repeat the HSV again and go back to your clinical picture and say, oh, look here, this is not a focal encephalitis, so I won't buy the diagnosis just because the lab has said. Okay. And patient had a hyponatremia. Now it is very significant, 116. So probably the present deterioration in level of sensorium may be due to hyponatremia, clinical worsening and all that. Okay, next slide.
Yes. Then repeat MRI was done on June 21st. It revealed a decrease in the edema previous granulomas, and there are acute lacunar infarcts noted in the right superior cerebellar peduncle, right parietal subcortical region.
Okay, anyway, these are non-specific. What happened next?
And CT.
Yes, the regime of pulmonary and TB meningitis, I will talk in my talk now. Yeah, please carry on. Jai Shankar, where did you disappear, man? Hello, Jai Shankar. Okay, so in view of the granuloma, they wanted a diagnosis by looking at the presence of tuberculosis elsewhere, and they found that there is a retroperitoneal lymph nodes. So there's a question about the partially treated pyogenic meningitis. Now, there is always a confusion whether the patient is partially treated or not. Remember, partially treated pyogenic meningitis will have some percentage of polymorphs. So there must be 30%, 40% polymorphs. There cannot be 90%, 100% lymphocytes. Number one. Number two is clinical. If the clinical picture is an acute infective meningitis, then you think of it as a bacterial meningitis. You look for gram stain culture and all that. You don't only make a diagnosis on CSF basis. And the patient should have received quite a number of days of anti-pyogenic treatment. So I will tell you about the CSF when it comes to partially treated pyogenic meningitis. What is important is, in partially treated pyogenic meningitis, the cell count comes down first. The glucose comes down and then the cell count. So you will find that the glucose level will tell you about the partially treated or a chronic meningitis. And then the next question was granuloma. Can granuloma occur in 5 days? It is not that granuloma has occurred in 5 days. We have made a diagnosis that there is a granuloma at that time. See, somebody comes with a focal seizure, first time in life. You do an MR brain. There is a big glioma sitting there. You think glioma has come 1 hour ago? No. Glioma is there for several weeks or months. Or a meningioma may be there for years. But it has manifested on that day. So similarly, the granuloma manifested radiologically on that day. It doesn't mean it has come in 3 to 4 days. Yeah, so the granuloma was not visible in the first MRI for reasons we do not know, or clarity was not there. But in the second MRI, yeah. So here the point I want to make is, the CSF shows HSV PCR positive. Don't jump to the conclusion that this is a HSV encephalitis. Always remember, clinical diagnosis is extremely important. All laboratory investigations must add on. No laboratory investigation will give you final diagnosis, including histopathology. So if your clinical diagnosis is A and the lab says it is B, check your clinical diagnosis and then check your laboratory. See, nowadays CSF sample, they will do some 25 tests in one CSF sample. So it is very difficult to say that final diagnosis is because HSV positive. HSV has got a totally different picture. It is a focal encephalitis. I will tell you in my next 15 minutes my talk. So in this patient, if you see HSV PCR positive, you do not change your diagnosis. You repeat the HSV again and go back to your clinical picture and say, oh, look here, this is not a focal encephalitis, so I won't buy the diagnosis just because the lab has said. Okay. And the patient had a hyponatremia. Now it is very significant, 116. So probably the present deterioration in level of sensorium may be due to hyponatremia, clinical worsening and all that. Okay, next slide.
Yes. Then repeat MRI was done on June 21st. It revealed a decrease in the edema, previous granulomas, and there are acute lacunar infarcts noted in the right superior cerebellar peduncle, right parietal subcortical region.
Okay, anyway, these are non-specific. What happened next?
And CT.
Yes. The regime of pulmonary and TB meningitis, I will talk in my talk now. Yeah, please carry on. Okay, so in view of the multiple, granuloma, they wanted a diagnosis by looking at the presence of tuberculosis elsewhere, and they found that there is a retroperitoneal lymph nodes. Jayashankar, are you there? Okay. So they did a biopsy of the retroperitoneal lymph nodes, and it turned out to be a case-eating granuloma, thereby confirming that the patient has tuberculous lymphadenitis there. And as a corollary, with all this clinical picture, it was a TB meningitis, which incidentally happened after the vaccination. You know that there is so much of wrong advertisement for the vaccination. A fellow who has got vaccination today dies of heart attack tomorrow. They'll say, oh, patient had a heart attack because of vaccination. And now people will say, patient died because of vaccination, because of some meningitis and all. Our patient relatives will say they developed meningitis and encephalitis because of vaccination. So please remember, it is a very incidental. So the standard joke today is vaccination and COVID can produce anything and everything except pregnancy. That is the only thing people cannot complain of, that he took vaccination and became pregnant next day. Okay. So final diagnosis, acute meningitis, right?
So
okay, Jayashankar, I am taking over now. Okay.
Okay, sir. Okay.
Right.
Okay.
Now, let us just go through the clinical picture of this patient. First, we came to know that the patient had some non-specific symptom on day 1 and day 2. Then there is a specific involvement of encephalon. Why did we say involvement of encephalon or brain? Because the patient had acute confusional state. So what are the symptoms of encephalon involvement? Altered behavior, seizures, altered sensorium, which includes acute confusional state, delirium to drowsiness and coma. Patient may also have a neurodeficit like hemiparesis. Now we know that there is a involvement of the brain. Now the differentiation between encephalopathy and encephalitis I have already told you. Encephalopathy is a non-inflammatory, non-infective, whereas encephalitis is inflammatory with or without infection. Now there is a confusion in the students, what is meningitis, what is encephalitis. A pure meningitis does not involve the brain. It only causes involvement of the meninges. Okay. So are you able to hear, all of you? Hello?
Yes, sir.
Are you able to? Okay, you are able to hear. Right.
Yeah, able to hear.
So meningitis, only meningeal involvement. So headache, fever, vomiting, neck stiffness. That's all. There is no brain involvement. The moment there is a brain involvement, like altered sensorium, seizures, and neurodeficit, it becomes encephalitis. So if there is a history of headache, fever, vomiting for 1 week, and then patient became altered sensorium, we call it as meningoencephalitis. People who come only for meningitis, they will have only evidence of headache, fever, and vomiting, neck stiffness, no involvement of encephalon. So that is the difference between meningitis and encephalitis. Oftentimes in clinical practice, we see meningoencephalitis. Patients will come with headache, fever, vomiting, and rapidly followed by encephalitis. Very rarely we see pure meningitis. We see often encephalitis pure clinically, but there is a involvement of meninges also CSF wise. Now, encephalopathy and encephalitis, already Jaishankar has told you the difference. In encephalopathy, remember when you say encephalopathy, hyponatremia, renal, hepatic, hypoglycemia. So you find there is a fluctuating sensorium, whereas in encephalitis, it is a steady loss of sensorium. Patients with encephalopathy can have generalized seizure. Metabolic parameters are always abnormal. That is the reason why we make a diagnosis of encephalopathy. Whether it is a thyroid, liver, kidneys, glucose, sodium, there is a definite metabolic abnormalities. Metabolic endocrine abnormality is a must in encephalopathy. If they are all normal, then you have to go for toxic conditions. And most important, CSF is normal in encephalopathy, whereas CSF is abnormal in encephalitis. MR scan is normal in encephalopathy, but encephalitis may be abnormal, or it may be normal in the initial stages or non-specific, as happened in this case. So you find that two important investigations, the CSF and MR brain, both are normal in encephalopathy at any stage of illness. What are the causes of encephalopathy? We have already gone through that. Metabolic, electrolyte, endocrine, somebody has told, but they are very rare. B12 and all that, again rare. Hypoxic ischemic is a common in today's clinical practice. Patients come with irregular heartbeats, transient hypotension to the brain. So because there is a less blood supply, or a patient has a heart attack, we come to casualty, you revive them. Heart has started working, but brain has stopped working. So that is a hypoxic ischemic encephalopathy, which is the other causes of encephalopathy. So commonest cause are metabolic, then the hypoxic ischemic in our clinical picture. The important thing, all encephalopathy, fever, headache are usually absent. Another common clinical condition is patient has fever and has encephalopathy. When you do a CSF, it is normal. That means fever per se is causing altered function of the brain. Very commonly, they have either a urinary tract infection or a pneumonia. So you treat pneumonia or urinary tract infection, they become fully conscious alert. Now, how do you know systemic fever has caused encephalopathy and not a direct involvement of the CNS? by CSF examination. Patient has fever, headache, encephalopathy. CSF is normal. That means it is a systemic fever causing encephalopathy. Now, once you say the patient has encephalitis, then is it a general encephalitis or focal encephalitis? Now, again, this is an extremely important point to differentiate between the two. Now, why do you say general encephalitis and focal encephalitis? Because focal encephalitis has got a treatment in the form of HSV. What is the most important to differentiate? Conscious level will be normal in cases of focal encephalitis. Because to be unconscious, both hemispheres have to be involved, not one hemisphere. If it is a focal involvement, why should a patient be unconscious? Unless it becomes generalized later. So whenever you see a fully conscious patient with an encephalitis picture, what is encephalitis picture in focal? There is a focal seizures, hemiparesis, then you will find the patient has HSV. So HSV is diagnosed only when the patient is fully conscious at the time of presentation of the illness, but has got a CSF abnormality. So that is a focal encephalitis. The commonest cause and eminently treatable is HSV. Not so well treatable is autoimmune and paraneoplastic. What are the investigations? Routine lab tests we do for metabolic. Specific examination is MR brain, plain and contrast. So whenever there is so CSF examination is the gold standard for diagnosing encephalitis and to differentiate from encephalopathy. And the common causes of encephalopathy is a viral infection, generalized encephalopathy, focal encephalopathy is herpes. Now it is just a MR scan. The common viral encephalitis we see in clinical practice is JE, Japanese encephalitis, where there is a basal ganglia hyperintensity is a very common finding you find in Japanese encephalitis. So when you make a diagnosis of viral encephalitis, when you find this MR imaging, so it is very characteristic of the JE. As against this, you see the herpes encephalitis, which is a focal encephalitis. Patient is fully conscious, alert, confused, disoriented, personality changes going on for several days and doesn't become unconscious at that point of time. You do a CSF which is abnormal, infective, and do an MR scan, you see the focal involvement. Whenever you see an MR scan with bitemporal involvement like this, it is diagnostic of herpes simplex encephalitis. So the radiological diagnosis, if somebody puts you this MR imaging, bitemporal involvement is herpes simplex encephalitis. One-sided temporal involvement can be due to many, like glioma, abscess, tuberculoma, etc. But bitemporal involvement with a history of few days of problem is almost a diagnostic of herpes encephalitis. Now, this is a granuloma, we will not bother about it. Now, when you come to the tuberculosis, the drugs of tuberculosis, unlike systemic involvement, unlike systemic involvement, we want the drug to cross the blood-brain and blood CSF barrier. INH is bactericidal and has got a very good CSF penetration. That means INH is the most important drug in TBM. Rifampin is also bactericidal, but penetrance is very low. During the acute inflammatory process, all drugs will penetrate because inflammation causes increased permeability, capillary permeability. So during the acute phase, all drugs are penetrating, but a little bit down the hill, you find that only two drugs are effective. Most important is INH, the second is rifampin. That's why INH, rifampin is given for 12 to 15 months in case of neurotuberculosis, unlike in pulmonary, etc., where 6 months, 9 months is given. Now we give 12 to 15 months in both INH, rifampin. Pyrazinamide is a very good CSF penetrance, but it is only bacteriostatic. So in acute phase, we want to kill the bacteria, and after the bacteria are killed, We don't want it to regenerate again, bacteriostatic. So PZDA, ethambutol, streptomycin are effective. That's why we give INH rifampin for extended period of 12 to 15 months, and PZDA, ethambutol we give for 3 months for PZDA. That's all. Okay. Autoimmune paraneoplastic, I'll come back again. Now, some very important questions about the CSF. Let me see how many minutes are there. So only about 8 minutes. So should LP be done in a patient with altered sensorium? If MR shows no cerebral edema, LP is to be done. If it is a crucial for diagnosis. Patient is in a drowsy state, MR is normal, you can do a lumbar puncture if there is no cerebral edema. If you think it is going to give a diagnosis and a management. Or if you are worried, give mannitol first day and do a LP next day. Should we do CT-MR or LP first? If you are going to do both, then you better do a CT-MR, CT or MR and then do an LP. No point in doing an LP and sending the patient for imaging. But suppose you have to send a patient for imaging somewhere outside, it will take 2-3 hours to go. Or it will take 2-3 hours for him to get it done. And LP is important because you want to start treatment. Then you can do an LP. But there is nothing like if you are in the same hospital where imaging is available, get imaging and then do it. Is there anything like cautious LP? Because people keep on saying that cautious LP I have done. I have just taken out only 10 drops of CSF. 10 drops of CSF will not give any damn information. For a neurologist, 3 ml, 5 ml in one bottle and 5 ml in another bottle and 5 ml in the third bottle. We require 3 bottles, 5 ml, 5 ml, 5 ml. 5 ml for routine, 5 ml for add-on like tuberculosis, cryptococcosis, and another 5 ml for something more which you want. So don't give 2 ml for the lab and ask for so many investigations. Should we give antibiotics before LP? Yes, you can. When you suspect pyogenic versus viral, you can give antibiotics. Antibiotics will not change the cell count. It won't change from polymorphs to lymphocytes within 3-4 days or 5 days. Yes, it may give you a negative culture. The bacteria, if they are sensitive to the antibiotic, the bacteria may disappear. The blood culture may be negative. The CSF culture may be negative, but the cell count, protein, sugar will not change. So clinically, if you think antibiotic is a must, please go ahead. Should LP be repeated? No. If the patient is clinically improving, you have a definite diagnosis, no need to repeat MR, no need to repeat an LP. But as in this case, we are confused whether it is metabolic, whether it is HSV, whether it is tubercular or viral. So in that situation, you need to repeat the investigations. Is there a need to do blood glucose before LP? Yes, as you have rightly seen, especially in a diabetic patient, because we know that CSF sugar is 1/3 of blood sugar. Unless you know blood sugar, you don't know what is 1/3. You have to do it. Then CSF, when does it return to normalcy? First cell count will return, then glucose, and lastly the protein. That's why in TB meningitis, after 4 months also, you may find proteins are actually increasing. Sugar is normal. The cells are disappeared. So that is a stage of what we call as a spinal arachnoiditis with a spinal block. So remember, cells, then glucose, and then protein. Because glucose is consumed by bacteria, so inflammation is due to bacteria. So once the bacteria is dead, the cell count will come down. So the consumption of glucose will come down. So in this patient, you find the granuloma here. So I'm repeating the same scans which I showed. You see the granuloma here. You see the granuloma here. And this patient had abdomen CT and a chest CT to find out evidence of tuberculosis. And here you see the lymph gland here, retroperitoneal lymph gland. This is 1.75 centimeter and this is 1.37 centimeter. So our radiologist could go from behind and take a biopsy of this lymph node, which shows evidence of tuberculosis. And you will find somebody asked the postictal changes in the MR brain. There are some non-specific postictal changes. As you can see, some changes in the subcortical white matter. There may be, these are totally non-specific changes. Now, what is more important to understand is splenium diffusion images will show a hyperdense splenium. Now, this is again a non-specific condition which can be seen in so many non-specific infections, metabolic parameters, and even after a seizure. So, non-specific cortical, subcortical, as in this patient here, not this patient, as in some of the patients, or more important, when you see this, don't jump to a conclusion, you have come to a diagnosis. This is also non-specific. Septic encephalopathy will have normal CSF. Yes. What you mean septic encephalopathy means patient has sepsis elsewhere, maybe having a renal abscess, a liver abscess, or a pneumonia, or a simple urinary tract infection. There is a fever, there is an encephalopathy. To differentiate systemic fever causing encephalopathy and systemic infection invading the CNS causing meningitis, CSF, gold standard, CSF. So systemic encephalopathy will have normal CSF, no question at all. Has this patient improved with ATT? Hello, Jayshankar?
Yes, sir.
Huh?
Yeah, improved with ATT. She was sent home.
No.
Again, she came back with the UTI.
Pardon?
Again,
she came back with what?
After 2 days, she came back again.
What is now the problem? You see, anti-tubercular drugs.
The fever was there.
Anti-tubercular drugs will take a couple of weeks to improve. It's not like pyogenic meningitis, where you see dramatic change in clinical picture in pyogenic meningitis. In tuberculous meningitis, we always give steroids and anti-tubercular drugs, the 4 drugs for 3 months and 2 drugs for another 9 to 12 months. It is the steroid which improves dramatically the level of sensorium, and then the anti-tubercular drugs slowly take over. So if the patient has come in coma, the patient may take a couple of weeks to improve. So don't expect dramatic improvement the moment you start anti-tubercular drug. Is altered sensorium an indication for MRI scan? Sir, it is not altered sensorium, it is your clinical diagnosis. Patient has come for altered sensorium, you have diagnosed metabolic encephalopathy, and the sodium is 112, there are no focal deficits, there's no need for MR scan because you have got a diagnosis. But if you find the patient has no metabolic abnormalities and the patient is unconscious, you have got to do an MR scan. That is normal, you have got to do a CSF. HSV positive in this case, again, same problem. Clinical diagnosis is the master. All investigations, or I keep telling in my class, it is like wearing a tie. If you wear a tie, if you have got a coat, boot, suit and all that and put a tie, then it gives you a image. But if you don't wear anything and put a tie, you tell me what happens. It has got no value. So clinical diagnosis does not match with, in this case, does not match with HSV because patient's problem is altered sensorium, that means bilateral cerebral global involvement. There is no focal involvement as you see in HSV on the MR scan, and so I don't buy this laboratory report. I will repeat it. So I go back to my clinical, check. I don't agree with this after repeat clinical examination and history taking. Now, dosing of steroids in TB meningitis, when a patient is unconscious, we give 4 milligram 8 hourly or 6 hourly decadron, dexamethasone and taper it. The injection is tapered over a period of week, replaced with 40 mg of oral prednisolone, which is tapered over 6 to 8 weeks. 6 to 8 weeks. Provided the patient has neurological deficit and is in a semi-conscious state. A fully conscious alert patient with a seizure and there's a tuberculoma in the brain and the CSF shows TB meningitis may not require this aggressive treatment. We may just give only oral steroids for about 3 weeks. Another important point I forgot to tell you is about the CSF. to get a proper CSF, see, between encephalopathy and encephalitis, you want a gold standard CSF analysis. So you must do a CSF 5 ml into 3, send the CSF for immediate analysis. The cell count must be done preferably within 30 minutes. 30 minutes. The more you wait, the cells will degenerate and die. So what was 100 cells within 30 minutes, after 2 hours, it may become 30 cells and your diagnosis completely changes. So you have to send it to a lab and request the lab people to do the cell count first. Cell count first. They can do culture, gram stain later on. Cell count, then sugar and protein. Protein can be done later. It will be still there. Sugar can be there again, but cell count will disappear. So many times you find a CSF done in the afternoon. The pathologist will come next morning and look at the microscope and say there are only 10 cells, whereas the patient had 200 cells. So please remember, CSF should be non-traumatic, 15 ml CSF, sent to a lab where the laboratory technician and doctors are aware of how to analyze the CSF, not somebody who has never seen a CSF, and request them to do a cell count forthwith within 30 minutes to 1 hour. Then only you can make an interpretation of CSF for your diagnosis, because CSF is the gold standard for diagnosis of meningitis, encephalitis, tuberculous meningitis, pyogenic meningitis and all. So remember CSF, how to do it, where to do it, when to do it. When you are not sure the report is not right, send it to another lab, go your